one of our favorite topics, urine drug testing. I have no conflicts. We're going to focus today on your clinic policy and what factors might be important. I think one of the things that's very important that's evolved over the last 4 or 5 years is the use of marijuana, both for medical uses and now recreational uses in Washington. So I would say that your clinic needs to decide what you're going to do about that, and how you're going to approach patients who may be using it for multiple purposes. We're going to talk about the collecting and ordering processes. I want to help you understand the different types of UDT, the reports that are generated, a very brief discussion of the science and technology. We're going to talk, and we may even have some additional time to talk about interpretation of the results, also what you do with the results, communicating with the laboratory, which is an ongoing issue, a few frequently asked questions, and then we're going to talk a little bit about what might be coming down the pipe. We all know why we're here. We're here because of concerns of safety. We're using a technology that originally was designed for deterrent-based testing in our transportation industry or our addiction patients. And now with improved technology, especially with lower cutoffs, we're using this in chronic pain management. And as I've been reading in the popular press, as there's more and more discussion about the opioid issue in the first quarter of this year, one of the issues of chronic pain management is that it's costly, and one of the things that contributes to the cost is urine drug testing. So why bother? We're worried about safety, we're worried about medication adherence, we're worried about making an additional diagnosis of drug misuse or addiction. We want to encourage and reinforce behavioral change, that is for patients to take their medications responsibly and not use other medications. And it's now a requirement of ongoing treatment in most protocols for chronic opioid therapy. When you form your policy, you should have an understanding, at least verbalize yourself as why are you using UDT. The Center for Medicaid and Medicare guidelines want us to use these, but don't want us to overuse them. What are you going to do with the results? We're going to educate our patients. We may adjust dose. We may stop the opioids. So you should have a plan about what are you going to do with the results. You don't want it to just sit in the chart, which gets you to what are the goals for monitoring your patients and what are the goals of opioid therapy. We want to improve function, but we want to do this in a safe manner. There are 2 basic types of testing, and one technology is used for the first type. So point of care is an immunoassay test. It has a very high cutoff. Laboratory immunoassay is the same type of technology, but it has slightly lower cutoffs. It's an improved technology over the point of care. And then there's confirmatory testing, using chromatography, gas or liquid, and mass spectroscopy. Point of care is office-based screening only. It's an immunoassay with high cutoffs. One of the hallmarks is there are many false positives and negatives. In fact, there were so many in the 2 types that we used, we stopped using it because we weren't able to go forward clinically and make any reasonable clinical decision making, any clinical decisions based on it. You won't get benzodiazepines and you won't get fentanyl on the point of care tests. And it's something called CLIA waived. Here's my little critter that triggers my blurb on CLIA waived. You need to have training. You need to train your staff to be able to do this. And essentially what the Department of Health is allowing you to do is to do some laboratory work in a non-formal laboratory setting. But there are some stipulations, and the stipulation is that it can't be the be-all and end-all test. If you find something here that you need to follow up on, you need to do it with other technology. You shouldn't make significant clinical decisions which result in other testing or, for instance, in our case, dismissal from opioid prescribing based on this test. Point of care is a screening test. It measures drug classes only, and it measures fairly high levels, so there has to be a lot of the drug there. It needs to be confirmed, as I just said, both by the manufacturer and federal government. And if it tells you what you want, you may decide, if you have a compliant patient, you may want to stop there. These tests are costly, but if it doesn't tell you what you want to see, then you need to go further and send something off to the lab. It will never provide results on amphetamines versus methamphetamines. specific benzodiazepines or fentanyl. We don't have good point of care tests for those drugs at this point. The laboratory immunoassay, and as well as the point of care, it's an immunoassay test. It works on the basis of competitive binding. So structurally like compounds are going to interfere. They're going to bind to some type of receptor. Most often you measure metabolites. And here's the really important thing, and there are 2 or 3 important takeaways. Your test results are going to be read as positive or negative. If it says positive or negative, you don't have confirmatory testing. You have an immunoassay testing. There are 6 different tests. Different labs use different tests. Our lab, for instance, uses a different test for cocaine that is better. We only use an immunoassay test here at the university for cocaine because they feel it's so good. And we'll talk about why that is in a minute. And there are lower cutoffs than with the point of care testing for the laboratory immunoassay. Confirmatory testing is gas chromatography or liquid chromatography and mass spectroscopy. There are lower cutoffs, which may be more appropriate in chronic opioid therapy because we really want to know if the patient has the drug in their system or not. That's more important than the transportation industry when looking at cutoffs for their monitoring. Here's the second important thing. The test results are in numbers. They're in nanograms per ml. So if you see a number, you have a confirmatory test. If you see positive or negative, it's not confirmatory. But the numbers don't reflect the dose. There are some pain providers who will say, well, if I have a whole lot of hydromorphone, that means the hydromorphone is probably the parent drug and not the metabolite. But there are a lot of metabolic factors that we don't understand that go into that, and our toxicologist doesn't look at that. They may comment on it, but it's very difficult to drive clinical care by the numbers that you see, that is how many nanograms per ml. And billing is often based on each drug, but some drugs are allowed by the Center for Medicaid and Medicaid to be in combinations, and so you should ask your lab what combinations of drugs go with the test. So here's the science slide. So liquid chromatography, mass spectroscopy is the science that is used. And the mass spectroscopy offers the chromatographic separation and mass fragmentation of patterns that are characteristic for each medication. So what you see on the test result when you're in the lab is you see a peak. You're looking for your tree in the forest. There's a whole bunch of peaks there that the toxicologist is looking at. It utilizes isotopic dilution to quantify the medication. This is the quantification piece, and this is considered the gold standard for determining how much medication is there. However, quantitative excretion, and that's what we're looking at, how much drug is coming out, doesn't correlate to medication dose. In terms of validity of the specimen, it's something you might want to look at if there's something fishy about what's going on with the collection process. If you don't like the color, if the color's abnormal, if the temperature is abnormal, if there are excessive bubbles, or if there's unusual patient behavior. In the future, the 2 tests that I mentioned, temperature and specific gravity, will not be reimbursed by the insurance companies. So what they're saying is it's our responsibility as the collectors of these medications to make sure we're sending a valid specimen to the lab. Now this hasn't been dictated to us yet, but that is coming down the line. So an ordering process, you can do office-based testing, but you know that there are, and you monitor the patient's behavior. You should know that there are many devices and processes that I'm not going to go into that can foil the system. These are probably more important for you to know if you work in an addiction office. If you're very concerned about the patient's behavior, this may not be a good patient for you to be managing in your office. That if you're concerned, if they have a urinator or something underneath their clothes, there are probably other issues that make them not a good candidate for chronic opioid therapy in a primary care office. So when you collect the specimen from the patient, the first thing you should do is ask when they took the last dose of all prescribed medications. If you only give them 30 oxycodone, or if you give them 60 and they've taken it all and the last was taken a week ago, if that's why you're doing the test, you may not want to bother because it's probably not going to be there. Now, if you're doing it to look for illicit substances, you still want to do the test. Ask them if there are any unexpected substances to be found in the urine. Give them a chance to come clean, and you may decide you don't need to do the $600 test if they say, yes, I went to a party and snorted cocaine. You still need to deal with the fact they did that, but you may not need to do the test. And then tell the patient why we're doing this. We're really looking at safety. And don't forget to look at the PMP, which I actually like more than urine drug testing. All right. So this is a volatile topic. Let's keep going. Here's a reference card that we put together. It has most of the standard drugs. We don't have buprenorphine on here. I think it's a quick reference. There's a corollary to this, and I give this to my fellows, and I put this on the back, and my slide's so old, the hydromorphone is sinking down. But it's dropped over the last 5 years. If you look at hydromorphone, it's a metabolite of a number of different things. It's a metabolite of codeine, of morphine, and of hydrocodone. So it's going to be a common metabolite that you see. You need to know this, because if you see that, it doesn't mean they're taking Dilaudid. It means it's a metabolite, or it may be a metabolite. But do look down below. It has nothing to do with oxycodone. So if you're prescribing oxycodone, the patient has hydromorphone, you have a problem. So the good news and the bad news, and this is specifically about immunoassay testing, cocaine has a very high specificity. It is a local anesthetic, essentially. It looks different. So many labs will just do cocaine immunoassays, and that's what our lab does. They spent many years sending it off to the Mayo Clinic because we don't test for that here. They feel it's a good test because of its structure. Amphetamines, on the other hand, have a low specificity. They're problematic, and you need additional testing to see what amphetamine you have and if it's really there. Your toxicologist, which may become your friend and a good friend if you do a lot of these. Some laboratories have written comments accompanying results. If you're going to do urine drug testing, talk to your toxicologist and find out when they do this. Our lab will do it, but only under special circumstances. Our circumstances are, we need to put down what drugs we expect to see, and we need to tick a certain box, a certain kind of test, and then they will take it on through the process and go on to confirmatory testing until they find the drug we're interested in. You need to find out how your lab does that. If you're not sure of how to interpret a result, call your toxicologist. You can't know everything. It will provide backup in a difficult conversation you might have with a patient, and it'll educate you, and you probably won't need to call as much in the future. There are many reasons for negative tests, and what I say by a negative test is the drug you want to see there not being there. So the patient didn't recently use the medication. The patient excretes or metabolizes the medication at a different rate than normal. Now, we hear patients saying, well, I'm a high metabolizer, a low metabolizer, and I'm seeing some test results coming back from labs where they will document that the patient's a high or low metabolizer. When I talk to our lab medicine people or any other academic lab medicine person, they say that is very difficult information to interpret because many things go into excretion and metabolism. So we really don't know that. What we do know is some drugs affect metabolism, especially the HIV drugs and the TB drugs. Rifampin and HIV drugs are very difficult, and they will speed up metabolism through the cytochrome P450 system. That's probably an important drug. Those are important drugs to know if the patient's on. Other than that, the high and low metabolizer, the science is not caught up with what we're now seeing in clinical use. Another reason for a negative test is the test was not sufficiently sensitive. That is, you did an immunoassay, there isn't enough of the drug, and you need to do chromatography. And here's the element we don't know how to deal with really, and that's clerical or technical errors. It's a lab test. It might not have gotten to the lab. Somebody may have mislabeled it. Don't really know what to do with that, but we need to keep that information in the back of our mind. Number 5 is a corollary to number 1. The patient isn't taking the current medication. Number 6 is something you should think about. The provider wrote a SIG, which is our classic SIG for oxycodone or Vicodin, 1 to 2 PO, Q 4 to 6 hours PRN. and they give 30, 60 tablets and the patient uses it all up. And you come in the third week of their prescription and they don't have any in there because they followed your instructions. I hear this all the time. If you want them to take a maximum of 4 tablets a day, tell them that. A maximum of 2 tablets, tell them that. Tell them you expect to see the drug in their urine, even if you only give them 60 tablets. Now, if you give them 10 tablets or 30 tablets, it's going to be harder to test for if it's a low-dose opioid. And the last possibility might be there's no good metabolic test yet for the particular drug, although all our opioids we can test for. So lab error, we need to know that we are not doing the most detailed testing. We don't monitor the patients. We're not witnessing. They don't slide the urine in a little door like they do in the addiction clinics or in the monitoring for impaired physicians. So there can be laboratory error, and there are a number of places where this might happen. You could consider this if you have unexpected results, but you need to put it in context of what you know about the patient. So now you've done a test and you're getting the results back, and what are you going to do? I think you need to go back to your policy. You've decided you're going to do urine drug testing. Who's going to have it? And it's recommended that everybody does. When depends on their risk and how often you do it. So you're starting with your policy. You need to figure out the marijuana thing because it's legal in Washington State. And I apologize for the people from other states. It may be coming to your state as well, but it's we need to think about what you're going to do about that. You need to include things in the patient care agreement. And that patient care agreement is now, they're now talking about shared decision making. So it's, I think, to soften the blow, we're not just imposing this on patients, but we want to have them at least understand why we're doing this, even if they don't agree. Our urine drug tests are not random. Patients come in for their refill. They come in for their appointment, and surprise, surprise, they're going to get urine tested. So if you're concerned about the patient, what you might find in the urine, you need to discuss the concept of callback urine drug test. That is, you call them up within 24 hours, you expect them to come and provide a sample in your clinic. That's going to be much more random than doing a urine when they come in for their refill. So here's this black hole slide that I've been using for a number of years, and I've kept it in here because what the literature hasn't, it's told us about urine drug testing. We now have policies because of the safety issues, but what we don't have yet is evidence to tell us what to do with these results, especially when we find aberrant results. So what do we do with the test results? We know we can't diagnose diversion, and you get a lecture on diversion through this program. This test does not, the urine drug test does not help you with diversion. It may make you think about it, but it doesn't diagnose it. Who should get second chances? Which diagnosis is appropriate for opioid therapy, and how to approach marijuana? So where I'd like to start is review your data. And I start with all the data on what the patient is on, but let's talk about UDT. We really want the first lines. We want compliant, prescribed drugs there, non-prescribed drugs absent, and illicits absent. But what happens when other things happen? What happens when illicits are there or prescribed drugs are absent? What are the risk factors? So here, we're going through all our data. What is the dose? What are the comorbidities? Does this patient have some impaired metabolism, liver failure, congestive heart failure? Do they have other safety factors such as OSA? When they're on high-dose opioids, you're going to combine the OSA with central sleep apnea. And do they have an addiction history? And these are well-documented risk factors. What about aberrant behavior? Again, you're reviewing your chart data, so you're reviewing everything you know about this patient. So what are your options? Well, you could just maintain the current prescribing plan. You have an aberrancy, and you've weighed all the factors, and you say, okay, I'm going to just continue. You may choose more frequent refills, such as weekly or every other week, but you may say, I just need to lower the dose. If you're going to give a second chance, you may want to structure it. What's going to keep this from happening again? You could stop opioids, or you could go on to have an additional consultation. For mental health issues, for addiction medicine, to use other strategies besides overtaking the opioids as a coping strategies. There are really no specific studies. However, there is one group from the VA in Philadelphia that did look at things, and they found that when a patient has greater than 4 aberrancies, they're more likely to have an illicit substance appear in their urine. Now, this is 4 aberrancies over an unspecified period of time and unspecified aberrancies. But we do know from this Philadelphia VA group that there are more patients with illicits present in their urine if they have a history of cocaine substance abuse. So cocaine seems to be a bad actor. So what is the pain? What is the diagnosis? Why are they on chronic opioid therapy? Has the patient been adequately worked up, which is kind of at the very beginning of chronic pain management? Is the patient participating in their care, and is the patient as functional as possible? Again, all the data that you're putting together in your decision making. What about marijuana? There are no specific data on the positive or negative effects combined with opioids. There's a hint of some data combined with alcohol in looking at forensic data from automobile accidents. It is a sedative, or at least a THC variety of sedative. There may be some benefit in some chronic pain states. We don't have really great data on that yet, but we're doing. So whatever your action is, especially if it's out of the box, you need to document. I can't say that it's completely unreasonable to continue to prescribing if someone took their spouse's low-dose opioid, but you need to explain the chart while you're doing it, and you probably can't do it for every single patient that has that aberrancy. So we had this boon in drug testing. You heard me say that even the popular press is talking about the cost of opioid therapy. There were some ethical issues that came up a few years ago, and what it said is that physicians were getting kickbacks. I don't think that's happening as much anymore. But they brought up the question of, are the results accurate, and when is the lab wrong? And we don't really have a good answer for that one. So what are the pitfalls? The pitfalls in urine drug testing is it's not a good test if patients are taking very PRN medications. So if you give them just a few pills a month, you're not going to be able to monitor with this. If you're looking for that drug, if you're looking for illicits, it's another thing. It's not a test for diversion, and it should be one data point, and you should be putting together all your data, not just the urine drug testing. So what are some frequently asked questions about urine drug testings? What help are the numbers in quantitative testing? We really don't have good evidence that they are, but I can tell you that a number of pain specialists will look at the numbers, especially of hydromorphone. If it's really high, they would expect hydromorphone to be the parent drug. But I think that takes a little bit more expertise than many of us may have, and also a little bit of a leap of faith. Can patients act as their own controls in terms of quantitative testing? And I've asked each of our toxicologists, all 3 of them at the U, they say no. What do you do about marijuana? When I first made this slide, we had our AG, we were invited one of our AGs to weigh in. They weren't very helpful. It's hard to know what to do with marijuana. We have at our CME course a couple of years ago, and we'll have again this year, Dr. Robinson, who is volunteering to review the data on marijuana. We don't have really solid data for any particular pain diagnosis, but it is being looked at in a number of areas. Centers for Medicare and Medicaid are formulating new guidelines. They circulated a draft a couple of years ago, and I still haven't seen firm guidelines come out. Essentially, what they want is better documentation to substantiate the cost of the testing. I think we should probably get used to writing in our note why we're doing the urine drug testing, especially if we want to do confirmatory testing. I think there's reasons to do it. We don't know what reasons they're going to want, but I think we should begin thinking about that so we can be ahead of them. Here are a couple of statements that I put together. I'm ordering an immunoassay screen to detect the presence of whatever you're looking for, and the non-prescribed substances. You'll go on to confirmatory testing under what conditions, when you don't see what you want. Screening for illicit substances is ordered due to addiction history, somebody else living in the house that has that is addiction, or if an abnormal UDT, a high ORT. explain why you're doing that. And we will be asked to do these things at some point in the future. So in conclusion, in terms of the type of test, the most sophisticated is the easiest to interpret because it has numbers. It's the most reliable and most expensive. We still don't have data to help us support what action is generated by the results. We need to think about that. And it's up to our clinical decision making at this point because the literature isn't a lot of help at this point. CMS guidelines will impact the test orders. I think we should get ready for as much documentation as we can put in there. And remember, UDT is only one tool.